Welcome back to this antibiotic series. In this video, we'll discuss about the pharmacokinetics and pharmacodynamics that actually matters, especially in the ICU setup, and why dose of an antibiotic is just a lie and in sepsis. So this is medicine beyond Harrison's. This is completely for educational purposes. Let's get started. So IDSA suggests that antibiotic choice without knowing the pharmacokinetics and pharmacodynamics is utter useless. So understanding is without understanding of pharmacodynamics and dynamics leads to incomplete therapy and often failure of antibiotic therapy. So this is non-negotiable. You must know about the pharmacokinetics and dynamics. So in ICU setup, there will be a lot of capillary leak. There is hypoalbuminemia due to negative acute reaction. Then augmented renal clearance. Then acute kidney injury. The patient may be on CRRT. The patient will have vasopressor support. In all these scenarios, the standard dose of antibiotics fails silently, and the bacteria might not be cleared off, may lead to failure and mortality. So these three concepts you must know to understand about the pharmacokinetics and dynamics. These are the three different mechanisms of which an antibiotic acts. So forget all the complex formulas, master these killing modes if you want to become a good physician. So time dependent killing, so especially for beta-lactam antibiotics, these are the time that the antibiotic is above the target range of minimum inhibitory concentration. This is the minimum inhibitory concentration. The time of antibiotic above the minimum inhibitory concentration is what is important for beta-lactams. So the rule is prolonged infusion. So for example, piperacillin tazobactam should be given over 4 hours, so that once in 6 it is given Q6 hourly, and every time it's given over 4 hours. So throughout the time period of 24 hours, the antibiotic level should be above the minimum inhibitory concentration. So another type of killing method is concentration dependent killing, which is especially suitable for aminoglycosides. It has a peak effect to the minimum inhibitory concentration. It just goes to the peak and drops down, hit hard and once. That's it. So then the third type of killing concept, killing mechanism is that area under the curve of above minimum inhibitory concentration. So this is what is important. So this is the area that is above the minimum inhibitory concentration. This area is what is needed. Then the amount of time the antibiotic is above the curve. So total 24 hours dose should be given for vancomycin and fluoroquinolones. So that is what is the concept. Time dependent killing for beta lactams, they keep the free drug above minimum inhibitory concentration for 40 to 100% of the dosing interval. So more frequent or more prolonged the infusion is superior to higher bolus doses. So this is the basic prime concept that you must know. So Meropenem 1 gram IVQ 8 hourly is given. It should not be infused over 30 minutes. It leads to ineffective in resistant bugs. So it must actually be infused over 3 hours slowly, such that so uh, such that it maximizes the target above the range, above the minimum inventory concentration time above the range. So same dose, radically different efficacy is there. So yeah, Meropenem is given over 3 hours. That is the concept from this time dependent killing. So concentration dependent killing for aminoglycosides, you once daily standard dosing, hit hard ones, do not drizzle. So avoid divided dosing leads to toxicity risk rather than efficacy. Maximizes peak and minimum inhibitory ratio. This is what is important. The peak to minimum inhibitory concentration ratio is what is important in case of aminoglycosides. For vancomycin, it is the total exposure over 24 hours, moved from the trough, that is area under the curve. Loading dose should be 25 to 30 milligram per kg, and always watch for acute kidney injury risk in case of usage of vancomycin. So in case of sepsis, the patient will have increased volume of distribution. So sepsis, there will be IV fluid therapy, there will be hypoalbuminemia. So all these leads to a lot of third spacing. So hydrophilic drugs are easily diluted in such scenarios, such as beta-lactams and aminoglycosides. So if you give the standard dose, for example, piperacillin tazobactam of 4.5 grams, initial doses will not reach the above minimum inhibitory concentration because of large volume of distribution, and will further lead to under treatment. So IDSA role is loading dose is mandatory in sepsis. So even in acute kidney injury or renal failure, this is misunderstood by most of the physicians. So loading dose should not be skipped in case of sepsis. So area augmented renal clearance. So this is a concept where creatinine clearance would become more than 130 ml per minute in case of young persons, trauma, sepsis survivors. In all these scenarios, the drugs are cleared faster, which leads to subtherapeutic range in treatment and not reaching the minimum inhibitory concentration, further lead to drug failure. So always normal creatinine is not equal to normal exposure. Keep that in mind. You always calculate the EGFR. So, in case of hypoalbuminemia, the free drug works. Highly protein-bound drugs are affected, such that ceftriaxone, ertapenem, and daptomycin. All these drugs are affected due to hypoalbuminemia. The altered binding changes clearance and the efficacy of these drugs. So, these are highly protein-bound. When it is not protein-bound, when there is hypoalbuminemia, these drugs are easily cleared out by the kidneys and lead to drug failure. The CRRT, and the many patients will be on continuous renal replacement therapy in the ICU. These removes low molecular weight substances, low protein binding, and hydrophilic drugs. So mainly the beta-lactams and vancomycins are affected. So beta-lactam are usually avoided in such scenarios of usage of CRRT. So the standard doses will always fail. So go for an higher end doses. So practical ICU dosing rules. This is taken from the Sanford and IDSA based guidelines. So President Azobactam, if you are giving, you give it over extended infusion for over 4 hours. So it's given usually Q6 hourly and give it for every 4 hours. So Meropenem, give it over 3 hour infusion. Cefepime also give us an extended infusion. Ceftriaxone standard infusion is okay unless there is augmented renal clearance. Aminoglycosides are always once daily loading doses given. Vancomycin load at 25 to 30 mg per kg plus area under the curve guided loading dosing strategies. So failure pattern, if you the pattern one is the right drug, but the infusion time is wrong, then there will be persistent bacteremia without any clearance in the bacteremia. So pattern 2 is without giving loading dose and fear of AKA due to the fear of AKA, it results in early mortality because there will be high volume of distribution. The drug may not be even reaching the therapeutic concentration. So pattern 3 is young patient with augmented renal clearance and normal creatinine results in low exposure of the drug to the body and leads to failure. So, for example, if you have a urosepsis case with a gram-negative bacteremia, which is a non-ESBL E. coli, that is, it means it's sensitive to ceftriaxone. The best care of access is to give ceftriaxone 2 gram IV once daily. In case of severe sepsis, you can consider 2 gram BD initially for the 1 day to increase the loading dose. So, many scenarios in Indian setup uses ceftriaxone sulbactam. So, it is ideally not recommended due to variable serum levels, less predictable pharmacokinetics in sepsis compared to ceftriaxone. In most cases, it gets the job done. The bacteremia is usually cleared off. So this is pharmacokinetic and dynamic reasoning, and it's not a guideline-based thing that we do to treat an microorganism. So IG strategy, drug dosing strategy matters more than the drug of choice. So when you choose a drug of choice, always know about the dosing strategy. Again, coming to tell that piperacillin tazobactam is given over 4 hours, meropenem is given over 3 hours, and all other drugs are given accordingly. So hope you learned something in this module. One last main thinking is why can meropenem fail in septic shock despite in vitro sensitivity? So for example, when the culture is showing meropenem is sensitive, and if you give meropenem, the drug can entirely fail. So why it can fail? Based on this module session, hope you learned something about the concept of drug dosing and the pharmacokinetics and dynamics. If you know the answer, leave it back in the comments. Let's meet in another video in this antibiotic series. Thank you for watching. This is Medicine Beyond Horizons. Let's catch up in another video.